I just have a few little announcements to make. One is I wanted to remind the committee of the dinner tonight at Pulaski Tech. There will be transportation. 7:15 is the time, and it's leaving the Capitol. The transportation is leaving the Capitol at 6 o'clock, and that will be from the tunnel. And you will return by 9 o'clock, and Representative Mary Broadway has been coordinating this event. And where is Mary here today? I don't see her, but if you have questions, you can call her. I think that's going to be something that will be very meaningful to all of us, and I encourage you to attend. The other thing is I'd like to remind the members of the Senate Public Health and the House members of Public Health to keep your questions focused and make your remarks as short as possible. And then the chair would require those who are presenters to listen to the questions and focus on those questions, and please have your answers as direct as possible. And if you don't know the answer, just say, I don't know. I'll get back to you. And then when you have that answer, if you would let Mr. Price have a copy of that, and he could send it out to the other members. And committee, if you would mark your calendar, the May meeting of the Senate and House Public Health Committee is scheduled for Tuesday, May the 27th at 1 p.m. and Wednesday, May the 28th at 9 a.m. All right, with that, we will go to item D, the implementation of the private option, and I believe our director, John Seeley, and Dr. Allison will be presenting that. Yes, and we do have someone from Optimus here, and we're looking forward to their report. So if you would just identify yourselves for the record.
Thank you, Madam Chair. I'm John Seeley, Director of Department of Human Services.
Mandy Allison, the Director of the Division of Medical Services at DHS.
Madam Chair, my name is Stephen Schramm. I'm the founder and managing director of Optimus.
All right, you're recognized for your presentation.
Thank you. We'll try to keep the presentation relatively brief, because we simply be lots of dialogue. Of course, since the session, we have continued to work very hard on the private option, including implementing pieces related to the special language that came through. I believe the committee should have all gotten a copy of our latest enrollment numbers by county. It looks like this, and there's some data behind it. Really, what the data showed was across the state, we really had a very robust enrollment. It just seems to be a very popular program, and people seem to see the need for it. There are a few things that stand out about the enrollment information. One is about 60% of the people who have enrolled thus far, we have determined eligible, applied and determined eligible. About 60% of those are women. The vast majority are younger age. I believe our average age is about 39. So we continue to see that we have a young population, which obviously makes for a healthy insurance market. And then I think the other important piece that we see from this data is about 80%, I think the number is actually 82% of the people who have been determined eligible would not have, their income is so low, they would not have qualified for any help with their insurance coverage were it not for the private option. In other words, they're below 100% of the federal poverty levels. And as you recall, had we not done the private option, people above 100% could have gone into the exchange. So the vast majority, 4 out of 5 of these people who are primarily women, primarily younger, would not have had access to any assistance in health coverage. So we feel like this is going well. We'll continue. As you know, the federal marketplace, above 138% of the federal poverty level, that enrollment has generally ceased with some exceptions. The private option enrollment will continue. It may slow down some, although, again, thus far, we're just seeing kind of steady enrollment across the state. So we're pleased to see that our system seems to be working relatively well. We'll continue to improve it. But we're generally pleased with it. Dr. Allison, do you want to add anything on enrollment at this point?
No, I would not. Just to emphasize that enrollment has case over the last several weeks. We have not yet seen a reduction in the interest for coverage. So we reported through the end of March, and I'm sure that when we're ready to report for future periods, we'll see higher interest still.
Madam Chair, we continue to work very hard on the health savings account aspect, or our version of health savings account, the independence accounts. And if people want to hear about how these work out, we can get into that. Otherwise, I think we'll move directly to the work that Optimus has done. Of course, there were questions about what's happening with premiums compared to what we expected, and what's happening with people who actually see are enrolling, as opposed to those who we predicted would enroll. It was kind of a best estimate at that time. And as you all received the Optimus study saying, here's what we now see and where it goes from here. Dr. Elson, I may have just done leading. You may want to do more leading to this, and then I think we can ask Cindi Crone to kind of describe what their report says in summary, because it gets into a lot of technical detail, and really kind of what they see for the state from here in terms of where the work is going.
That's a terrific lead-in, boss, and I will turn it over to Mr. Tran to explain what he did for us.
Let me just ask the committee if there are any questions that pertain to the health savings accounts. I think this is maybe a good time for that, and then we'll go on to the study. Are there any questions pertaining just to the health savings accounts? All right, Senator Flowers, you're recognized.
So I understood you say you're working on that, setting up. That will just be for our design for the private option enrollees, is that right?
Yes, ma'am.
Okay, and how much, do we mandate how much savings percentage?
It'd be helpful, it might be worth taking just a couple minutes of time. For the concept, that would be helpful to
Yes.
consider.
The answer to your question is no. We did not, in the review of the independence accounts, when they were first included in the Health Care Independence Act at its inception, and also for neither when they were reviewed being enforced as a component of our appropriation this year, did we include an estimate of net cost or net savings or participation. It's described as a new program. We hope that it's a very successful program, and we have several objectives in mind in designing it. One is to help individuals below 138% of poverty, many of whom will, in a relatively short period of time, 1 or 2 years, see their incomes or family circumstances change and their poverty level increase above 138%. To help them gain experience making monthly contributions to cover costs that are associated with healthcare expenditures, to help them gain experience at the point of service with cost sharing or its alternative, prepayment, to help them learn to take personal responsibility for their health care, to give them experience with the healthcare system they may not have had before, in preparation for the next phase of many of their lives, which is premium payments, very meaningful out-of-pocket cost sharing, etc. And potentially to help them accrue some funds that would help them make that transition from the private option to the marketplace. Those are the goals. We are currently having informal discussions with vendors, for example, to find out what the just technical operational capacity of the health savings account might be as we continue to work on these policy designs.
How would the vendors necessarily be? Would it involve banks, people that would be the depository for the money that's in this health savings account?
I can't answer that question for sure. I know that there are some banks who operate the financing component of a health savings or independence account, but we may also see interest from other sectors, including insurance and others with capacity to do this sort of thing.
Okay, and so I would think from what you're saying and describing as the long-term possibility or short-term possibility of the change in going forward would be people coming out of poverty or rising above that poverty level. We're pretty much talking about young people, are we not?
Well, we certainly have a mix, and Director Seeley just went briefly over that, the demographics. We see in the private option a younger demographic than we see in the population, privately insured population as a whole. But we have a fair number of participants in their 40s and 50s and even early 60s.
Will we project and give a comment about people that you would expect not to be just staying in that percentage of poverty level? I mean, an older person that is, you know, limited education, not a lot of job prospects, I wouldn't see them
I'm sure
necessarily.
we'll have a mix of those who will or will not see their incomes go up or their poverty level rise over time. There are multiple purposes of the independence account. One of them is to help with those transition and make sure there's no disincentive to stay under a poverty level just to keep insurance, to avoid cost on the other end. So one is to help and facilitate that transition up. You know, not everyone can do up. Other purposes of the independence account include simply helping individuals take responsibility for the healthcare use that they have, whether or not they move up in income.
Well, are you all working with workforce services, workforce training, education for what you're saying just then? I mean,
We haven't, no.
would that not be a necessary connection? Somebody, some governmental division, agency to link with what?
So I think it's an interesting argument. What we want to do is make sure there's not a barrier to people improving it. We don't want them to be in a situation, because of the healthcare situation, say, I don't think I'm going to take that slightly better job because my healthcare costs are going to be wrong. We want to remove that barrier, but I think to your point, we probably should work closely with RD and his staff to make sure they understand that's part of this program and share that information. We do not intend, and I don't think that's what you have, we don't intend to do job training as part of this. Or anything like that, but we do need to share the information. That's right.
Part. The last question I have is about a percentage of people that, did we mandate you to get a certain amount of people, percentage of people from that private option enrollment to participate in these health savings accounts?
No.
Okay, so are you all then, you all are making up rules to go? I mean, what are you, exactly what are you doing?
We're preparing options that we will certainly bring to policymakers and I'm sure including this committee to review.
So the people in the private option, I mean, it's not like they're going to be mandated, ordered to do this. I mean, is it going to be a choice, an option for them?
In fact, one of the purposes of the independence accounts is to help encourage appropriate choices. So choice will certainly be involved.
But it's no penalty if somebody decides not to.
What I would say is there certainly would be a difference in outcome for those that do and don't participate, and that difference in outcomes and incentives is part and parcel of the design of the independence account itself, and will be the subject matter before this committee and other forums when those options are brought forward.
And I would say no one will lose coverage. If for some reason they decide not to, or find themselves capable of participating, they would not lose their coverage.
What would be the consequence if they decided not?
That's one of the options that you'll have to decide. We'll bring choices to you, and the consequence of participating or not participating is one of the choices that the state will make.
I think we need to know who these vendors that you all are trying to, I don't want to know. I mean, and is it a profit for them? I mean,
We would expect so, yes.
well, I'd like to know who it is, what it is, and what kind of profit would be expected.
I think maybe at some time you might be able to.
We will, I'll clarify, that we wouldn't expect to turn over these sorts of choices to a vendor or to put before them the opportunity to make money on the backs of participants. We would be looking to vendors for the operational role, the mechanical role of managing accounts and enrollment and interacting with providers. All of the policy choices, all of the incentives are the state's to make, and we wouldn't be changing that.
One last question. Could a person not hold their own money? I mean, why would you need necessarily to deposit something in a particular vendor's deposit? I mean, why not allow or consider allowing the person whose account it is to choose where they want to invest, or if it's a matter of making interest on some money, why not allow them to pick and choose?
So the disposition of ownership for funds in an independence account or a health savings account is a question that the state and the federal government will have interest in, and is part of the policy choice that you will have to make when those options are presented. It is administratively difficult to administer independence accounts through multiple and independent financial institutions or other vendors. I have some experience with that question in the state employee plan in Kansas, and we just say there was an economy of scale to working with a specific vendor. But again, that's a conversation we could have either offline or when we bring this issue back.
All right, thank you. There are several people waiting to ask questions. Let me remind the committee that this is about the health savings accounts, and we do want to get to our Optimus study. And so let's, if you don't mind, please target the question and ask one and a follow-up, and then we'll put you back on the queue. All right, the next one is Senator Chesterfield, you're recognized.
Thank you, Madam Chair. Gentlemen, good afternoon. Where has this worked before? I want to say
There you go. Indiana is close to next. Madam Chair, Senator, Indiana's program is probably the largest experience with health savings account-like approach. Other states tried it under a previous waiver authority called health opportunity accounts, but did not see any enrollment similar to Indiana. Indiana's experience showed that it did reduce the cost of care when compared to traditional fee-for-service Medicaid.
so the other states, they had tried something similar, but they just give it up.
Madam Chair, Senator, the other states' health opportunity accounts were not as broad or as far-reaching as Indiana, and so never reached critical mass for enrollment. And so the actual authority for health opportunity accounts expired.
I'm gonna do this further, Madam Chair, before you shut me up. In this state where we have underserved populations as far as health is concerned, and health care is concerned, as far as points are concerned, how will you go about making sure that we have vendors in each one of those areas so that those citizens who would like to participate will be able to participate?
Those are the kinds of questions we're posing to vendors as we meet with them, and the kind of question that we would pose in the form of a procurement over the next few months to make sure that there was access.
So they make sure Indiana is the only one that has a rollout center trial.
In terms, Senator, in terms of the order of magnitude we're considering here yet.
The rest of them tried it, there you go.
Correct.
And you're talking to vendors without trying to set this up.
Correct.
Making at all areas of service of the state.
Correct.
Thank you, Madam Chair.
Thank you. All right, next on the list is Representative Wilkins.
Thank you, Madam Chair. My question is for Mr. Seaman. I think it's a pretty simple question. I may have missed something. I come in just a few minutes late, but on this total, on Exhibit D, on this total determined eligible, what does that mean? Are these people already signed up on a private option, or?
Is this a question about the health savings account? Okay, can you wait? We're still, Mr. Sealy said something about health savings accounts and taking some questions before the report, so that was where we are. Would you mind letting me? All right, thank you very much. All right, the next question, I believe, Representative Douglas, this is on the health savings accounts. All right, thank you.
Thank you, Madam Chair. And you may not want to answer this right now, but just things I'm curious, when you bring back the report on health savings accounts, will the amount of money that you put into the accounts be prorated according to their poverty level? And, how will you determine how much you put into the account? And if they don't spend it all, will they be able to roll it over into the next year and add up more for the next year? And if they're adding that up over a number of years, would they be able to possibly spend that on education or childcare in order to move them, into, try to help them benefit, to move them away from their dependence. So just some questions to consider as you're looking at health savings accounts.
Those are great questions. Those are the kinds of questions that we'll bring answers back to, and certainly the answer to the first one is yes, because the cost sharing obligations vary by income, at least at some level, and so the funding of an account would also need to vary by income.
All right, thank you. Thank you. All right, the next one is, I believe, Senator Sanders. You're recognized.
Thank you, Madam Chair. A couple of things, and I appreciate Representative Douglas's question, because those are precisely the types of key questions. And then also, I would say, one thing to consider is in terms of limitations on the time that a person can roll over those funds are very important. And again, we go back and read the original law and the things that we've talked about in terms of encouraging consumerism and doing things to discourage overutilization and encourage proper utilization. I think that's what we're aiming at. And I will share with the chair and a few others. There actually is data out there on this age eligible group and sort of their in relation with HSAs and what happens in terms of utilization, in terms of price sensitivity, all those things. I think there have been many folks who've talked about the private option not having tools to contain costs and control costs. And I think this was one that was included from the very beginning and from the get-go. And that is certainly one of the tools that we have. But the aim is teaching a population of individuals who've been excluded from health insurance, excluded from participating in what most people participate in when they go to the doctor. That exchange takes place with the healthcare asset, so I think that's important. I do also want to point out, which is a direct tie, appreciate Director Allison and what they're doing in Medicaid, and there's some positive press coverage about some of the impacts and innovative things that you're doing in terms of curbing ER use and overuse and non-emergency use of emergency rooms. So I want to appreciate Medicaid's role in what they're doing in providing leadership, as well as the private insurers. So kudos to your hard work.
All right, thank you. Last question on health savings accounts. Representative Hammer.
Thank you, Madam Chair. Dr. House, just asked you about the work factor in the consideration and development of the health savings account. I will let you know on the front end, one thing I'll be looking at in the future is how you're going to implement an expectation of gainful employment with the entitlement of being able to get the health savings account. So are there things in the discussion right now that are going to incorporate those two?
No, sir, there's not. The original distinction made in the design of the Healthcare Dependents Act was to use income as a proxy for an indicator of employment. It's not perfect, but that's one reason that you'll see in the Healthcare Dependents Act a distinction at 50%, for example, with the poverty level. So we don't currently have plans and discussed including a work requirement in association with the health savings account or dependence account, but instead included in the Healthcare Dependents Act a threshold of 50% of the poverty level.
So there won't be any connection in monitoring whether a person is trying to get gainfully employed to raise them out of the poverty level in connection with the health savings account and the money that they're going to receive for those health savings accounts.
Representative Hammer, we would be able, I'm sure we have means of tracking employment over time. That's part of the data that the Division of County Operations receives in the application process for coverage. But we don't have any current plans have developed options to tie the health or dependence accounts to present employment or work search. That we've been focusing on these other aspects of encouraging monthly contributions, really health insurance and health utilization related purposes.
Okay, and in their health savings account, last question, in my health savings account, or in their health savings account, will they have all of their benefits factored into the determination of how much is placed in their health savings account, such as if they're getting WIC or if they're getting SSI, or is it going to be a full gamut as far as all the benefits that they may be receiving that's going to drive how much is put in their health savings account? I'd like to ask that in your determination, what you're going to bring back to us as a body, that you be prepared to come back with an answer to that question, or how that factors in, or if you'd like to answer.
We'll be able to come back with an answer to that question.
Okay, thank you. Thank you, Madam Chair.
All right, thank you. I did overlook one person. I'm sorry. This question is about the health savings accounts, and it's Representative Farrar. You recognize.
Thank you, Madam Chair. Easy to over. How are we going to fund the health savings accounts? How are they funded?
So health savings accounts would be a different use of what we would hope is the same money within the private option. So, for example, including in the health savings account, the amount of money that would be paid in cost sharing that in lieu of actually paying the cost sharing. Or, for example, obtaining an amount of money from individuals on a monthly basis rather than through the cost sharing at the point of service in a provider's office. So the idea is to reduce overall utilization. The cash flow changes, the amount of, generally the amount and sources of funding are not intended to change. I would say that's one of the things that we would be testing is if they worked as intended.
But initially, we'll have to fund it out of adding the federal money.
That's correct, and then the issue turns to the disposition of that initial funding. Just because it's put into an account and needs to be large enough to handle potentially large out-of-pocket cost sharing does not necessarily mean that that money becomes the individual's if they leave the program 2 months later and don't use any health don't use any health care. So it's fairly complex. The disposition of those funds is complex, and again, that's part of the design that we would bring back.
Thank you. And I've got one more question. We talked about this earlier, but I want to hear the answer. When this population on their HSAs run out of money on their HSA, and they go to the physician, and they can't pay their taxes, do these people get care, or they refuse care, or how is that money paid if they do get care? Thank you.
Would you like me to address the question now, or when we come back and talk about options? It's a fairly involved discussion, because there would be more than one way that an individual might, for example, run out of funding in a health savings account. One of the design options that we need to take into account, and which we will bring back options to discuss, what if the individual does not make their monthly contribution? And you might be thinking of that monthly contribution in your question, and I don't want to put words in your mouth, but if you're asking what happens if they stop contributing and run out of money, we will be bringing options to address exactly that circumstance so that, for example, an individual would still have to pay out of pocket for cost sharing, that kind of thing. So we'll bring back options to address that circumstance, and it's a fairly involved conversation.
All right, thank you. All right, we appreciate that, and we will go on to our Optimist study. You're recognized.
Madam Chair, thank you, members of the committee. Optimist was asked by the state of Arkansas to produce a study looking at the original estimates that we provided for the implementation of the private option versus the updated budget neutrality estimates, and then a comparison to current experience. What we produced was a 7-page report. I'm going to highlight 4 key components of that today, and then open the floor at your convenience, Madam Chair, for questions. The 4 areas I want to cover, first is the March 2013 estimate that we provided. If you're following along on the report, this is the beginning of page 1 where we talk about the legislative process.
Excuse me, members, you were emailed the report, and I think we have a limited number of hard copies that we're passing out right now. Do you think we're going to need some more? All right. All right, well, why don't you go ahead with your presentation and we'll get some more copies.
Madam Chair, thank you. The March 2013 estimate that was provided as part of the legislative process was developed using 3 years' worth of Medicaid data. The most significant adjustment that was needed to make the Medicaid information appropriate for the private option population actually covered a number of areas. So not only did we have to adjust for differences in the population, but we also had to adjust for differences in the underlying reimbursement between Medicaid on a fee-for-service basis and the private option program. Whether Arkansas had chosen a traditional Medicaid expansion into fee-for-service, or whether it went down the path of expansion into the private option with the use of commercial insurance, it was clear that in order to secure sufficient access to services, that reimbursement to providers would have to increase. We had several conversations with the provider community here in Arkansas, as well as the insurance carriers, and we're providing estimates for the difference between Medicaid reimbursement, which we had grossed up to include all of the supplemental payments that exist within the state of Arkansas, and then moving on to commercial reimbursement.
In addition to the commercial reimbursement adjustment, I mentioned we made adjustments for differences in population. An example would be the primary population covered by the Medicaid program tends to be pregnant women and children. The private option is a broader cross-section of individuals, so we needed to make an adjustment for differences in age. What that yielded as part of our price estimate was a $437 estimate. Not only did that include the benefits that would be included within the private option, but also the RAP benefits that Director Allison mentioned earlier. Those are things like non-emergency medical transportation that are not included as part of a traditional commercial private insurance package. The $437 was produced in March of 2013. Then later on, in the fall of 2013, in August, we provided an updated estimate as part of the budget neutrality calculations. If you're following along in the report, I'm now referring to the section labeled waiver budget neutrality cost estimate on page 4. In this estimate, we actually had additional information available to us. So not only did Optimus do a complete actuarial analysis where we looked at population mix, service utilization, and assumed reimbursement, but we also had the benefit of the actuarial analyses conducted by the carriers that were participating within the private option. And so, in addition to our complete actuarial analysis, the commercial carriers themselves completed complete actuarial analysis where they looked at population mix, service utilization, and the assumed reimbursement. In that series of estimates, the number produced is approximately $477. That $477 does include the RAP expenditures that I mentioned earlier, the non-emergency medical transportation as an example. The difference between the $477 and the $437 actually depends upon which of the carriers' actuarial analyses that you look at and which of the components within our own actuarial analysis that you look at. Again, there are differences assumed in population mix, in service utilization, and in the underlying reimbursement between the 477 and the 437. Both of those represented projections of premium. First done in March of 2013 for the $437, second done in August of 2013 for the $477. We then fast forward to April of 2014, where we can begin to look at the emerging experience, but we're only able to look at the experience from an enrollment perspective. You need to remember that at this point, we're still within the projection period for the actual claims experience associated with this program. What I mean by that is we've had a ramp up of enrollment. We have not had a fully credible or robust data set developed yet for the claims experience. So what we're seeing now in the comparison of the premium experience currently versus the 477 is actually looking at variations in the mix of the underlying population. When we talk about mix, we talk about age factor, as well as the choice between and among the various carriers. One of the key differences that is driving the current premium experience, which is approximately $500 versus the original budget neutrality estimate that was $477, is a difference in the assumed age in the budget neutrality estimate of approximately 37 for the average age of the private option population versus the current actual experience for the first 4 months of the program of approximately 39 years for the average age. For every year differential in that average age assumption, it's worth approximately $10 per member per month. So the difference between the $477 and the current experience of $500 is about 2 years in difference, and it yields about $24 per member per month. As I said, we're not able to say this is a trend in cost experience. All this is an example of the mix of enrollment and choice being different from that which was assumed in the $477 budget neutrality estimate. The fourth point I'd like to make, and this is the bottom line, is, Madam Chair, as part of the charge to AID and to DHS to build a competitive marketplace for the private option, you have seen the development of additional carriers and options for insurance products that did not previously exist in Arkansas. As for the differences in the average premium at $500 versus $477, actually after adjusting for age, we are well under our budget neutrality figures, and we have confirmed with our federal partners that the budget neutrality process allows us to adjust that cap and target that was originally $477 to reflect these kinds of changes in age and choice going forward by October 1 of each demonstration year. And so after adjusting for age, we are underneath our budget neutrality target, and as my partners up here have mentioned, the program has well positioned itself moving forward with additional tools to continue to develop a competitive program going forward for Arkansas for the private option. With that, Madam Chair, I'm open to questions at your discretion.
All right, thank you. First on the list is Representative Farrar.
Thank you. Thank you, Madam Chair. For the increased cost, we appropriated $915 million this year for the private option. How much of that money do we have left out of the 915?
So the Division of Medical Services budget for medical services, which is inclusive of both the private option and the regular Medicaid program, was increased by $915 million. The expected expenditure included in that estimate for the private option is more than 915, but we only needed 915 more in the appropriation to fully fund. And that is for fiscal year 2015. So we're still in 2014 currently, and we remain on track to be able to stay within our appropriation this year and next.
So we have it. You can't tell me how much we used out of the 915.
We've used none of it.
None of it.
It's for 2015, and we're still in 2014, so we haven't spent any of that appropriation.
Just one more question. With all the price increases and things changing, at what point do you say private option's not going to work? Is there a number, a symbol, a sign? What is that?
That's a good question. It certainly wouldn't be a number that I would point to in April of 2014. As Mr. Schramm pointed out, we actually have, as of today, no more information about the underlying health expenditures for this newly covered population in the private option, those in the commercial insurance market now being covered. We don't have any more information on them today than we did last March. So we're still in the predictive period. Our actuaries, optimists, made a prediction. Later last year, the carriers themselves made predictions and turned those predictions into premiums. Those predictions and those premiums were higher than the 437 estimate that we came up with. They're both predictions. It will be hopefully later this year in the form of premiums that come in for 2015, but even into next year when we actually get data back on healthcare utilization for this current time frame, before we have hard, cold numbers to truly review the experience even of this first year. So it will be a transition to the market competition that I continue to predict will emerge and enable the state to benefit from, not just within the private option, but also others in the marketplace from that competition in the form of reduced growth in premiums.
So, I just also note in response to that, the success of the private option was never built just on the numbers. That the legislature, there's a lot of discussion about the fact that we obviously want to look at the numbers, but we want to reduce the churn of people going on to private insurance and off, and you just expanded Medicaid. You're constantly going on and off. There's less stigma of having people in the private market. I think that's worthwhile. There's certainly some benefit. I hope to, what we now have is about 150,000 people are eligible for this. So there are benefits that this body will need to take into account beyond just the cost. We will be comparing at some point as part of this 3-year demonstration, what does it cost compared to had we expanded Medicaid? But we'll also, I think, want to take into account, are people better off being in the private market where it sure looks like we'll have a lot more carriers and a lot more competition in the insurance market than we would have. I think we want to take all that into account when deciding whether or not to continue the private option.
Thank you.
All right, Senator Hendry, you're next.
Thank you, Madam Chairman. Just a couple of questions. And we visited about this earlier, Director Allison. I just want to make sure that I understood this. With regard to the caps, it's your presentation to us that those caps can be adjusted without federal approval if we just demonstrate that our assumptions about the demographic age is wrong?
Correct. It wouldn't rise, for example, to the level of a waiver amendment with a formal review, publication, and sort of discretion. They really have no discretion to reject the adjustment. It's simply a matter whether the demographics are different than we predicted.
Okay, so it's not really a cap, it's a calculated target number that we can adjust as necessary.
I would amend that by saying it is a cap. It's the first year in the calculation of the 3-year cap. The target is a good reference point of description for the first year, which can be adjusted as appropriate.
Okay, by nature, if you can adjust something back and forth, it's not really a cap, though. It's more of a target that we use for calculations, I guess, on down the road as far as whether or not there's a balance due. But again, if it's automatically adjustable without federal requirement, it's not truly a cap.
It's part of the rules of the game that the federal government has established. Think of it as the referee, and it's a way to keep the question and the answer fairly determined. And in this case, that fairness is determined by whether the calculation of the cap and the calculation of expenditures underneath that cap are a fair apples-to-apples comparison. Right now, they're not, because the expenditures underneath the cap are based on an average age of 39. The cap is based on an average age of 37. That's not fair, and the rules of the game is spelled out in terms and conditions of the waiver call for an adjustment in that cap in order to maintain what is the bedrock principle of those terms and conditions, and that is an apples-to-apples comparisons of spending with and without the waiver.
Okay, final question. There's been some discussion about comparing the cost of insurance through the private option versus traditional Medicaid expansion. And obviously, we've heard that we don't have any data really to compare that with. But I guess I would ask you, we do have data on the Medicaid that we've been providing for those 0 to 17% over the last years. That number is what per month?
I don't have that number in front of me today.
We don't have, I thought we talked about a number in the $300 and something range.
Let me defer to Optimus. That 365 is meant to be as close as possible to an apples-to-apples comparison of Medicaid under old reimbursement rates to Medicaid where it expanded, traditional Medicaid expanded with the new population.
I guess what I'm
Which isn't necessarily the same as what did it cost in the past for the 0 to
So you've adjusted that number, that 365 is a number that's been adjusted, assuming that we increase the rates under the rules of Medicaid expansion?
No, the 365 is without the increase.
Okay, do we know what it would be with the increase?
Director Allison's correct. The 365 has not been adjusted for the increased reimbursement.
And is the increased reimbursement, is that part of the requirement for expansion?
No, it's not a federal requirement to increase reimbursement rates in order to expand coverage.
Okay.
All right, thank you. All right, Representative Meeks, you're recognized.
Thank you, Madam Chair. My question is on the budget part of it, because you said that we allocated $915 million for the PO and private option in fiscal year 15. Currently at 155,000 people, which is what you say is eligible, times $496 a month, times 12, comes out to be $925.9 million, which is $10 million over what we budgeted for the private option. That is, if nobody else signs up, that is, if the per member per month stays at 496 and doesn't rise, which we've seen it now over the past few months, inch up a few dollars a month. So can you explain to me that if we're already over budget on the private option, what is the plan to be able to fund this thing through the whole next year? I think you said earlier you had kind of a buffer zone in case things did happen to increase. But
It's a very good question. Genuinely, there are a lot of numbers floating around, and the numbers apply to different points of comparison. So, for example, the waiver budget neutrality is based solely on a comparison of what it would cost to expand Medicaid versus what it would cost to serve the expansion population through the private option. And it really is just a comparison of cost for those enrolled in the private health plan, not even the medically frail, for example, part of the expansion. So that the waiver, let's say, window of focus is narrower than the comprehensive picture that we provided to the legislature last March, where we looked at all known costs and consequences under 3 scenarios: no expansion, Medicaid expansion, and the private option. The waiver is a narrower comparison. So let me speak to the appropriation, which is a bigger question than just the $477. DMS needed an additional $915 million in its appropriation for 2015 to fund both the private option and the remaining Medicaid program. DMS is part of the remaining medical services program. The predicted cost of the private option in 2015 is larger than that. Actually, a fair amount larger than that. So one answer to your specific question is that 915 isn't the appropriate number to have in mind as the cost of the private option in 2015. If you look back at the predictions last March, it would have been 1.6 billion, I believe. If you look, our current estimates have it in that range for 2015, up to and including an update for the enrollment that we've actually seen. One helpful point of comparison, the prediction last March for 2015, and also incorporated in our estimates of appropriation for next year, just in the last 2 months in the legislative session, actually assumed a fairly aggressive take-up rate. The estimates last March are based on the assumption that everyone would be enrolled everyone would be enrolled by December of this year. That's probably even more aggressive than we'll see. The estimates for the appropriation for next year were not quite that aggressive, but I think we are going to be fine. I don't think we're going to need any more appropriation next year than we've already asked for.
So the amount of, I guess I'm trying to get a figure without any buffer, whatever, what was your appropriation that you asked for the private option? Without Medicaid, without all the other things that you do, what was your office estimate was for the private option in fiscal year 15?
So I will give you a number, and I will say that that number isn't a specific appropriation because the appropriation was actually combined private.
Right, I understand that.
The portion of that that we predicted would be used on the private option was in the neighborhood of $1.5 billion to $1.6 billion in that range. Very, very similar to the optimist estimates either last March. And this, by the way, is having now knowledge of the premiums that we learned about last fall. So the predicted cost in state fiscal year 2015 haven't changed very much since last March, and were built into EMS's budget for 2015.
And then, kind of as a side question, if this is not online, just let me know, because I want to try to get a correlation between the private option and Medicaid, because I was very surprised to see last Friday when I asked about the $18 million that we transferred out of the rainy day fund over into Medicaid. Why didn't we take it out of the Medicaid trust fund? And I'm finding out that as of March 30th, we have $5.5 million left in the Medicaid trust fund, when last year we started with $79.7 million. And part of us passing the private option was to keep this from happening, was to stabilize our Medicaid. And I realized that, as part of the private option, we had 10,000 more people or so because they were medically frail put into the Medicaid. Can you?
Yeah, so in reverse order, if I could. The group you just mentioned, medically frail, who go back into Medicaid, are fully federally funded at 100%. It's the eligibility category that drives the rate of federal funding, not whether they end up in the private option or are medically frail in Medicaid. So they wouldn't add to any burden on state general funds. In fact, they help relieve that burden over time. We talked about this natural migration of individuals who would have been in regular Medicaid at a 30-70 match and will, by dint of the expansion, end up at a much higher rate of federal funding. The question of where the state share, the 30%, comes from for Medicaid is more complicated than I'm able to answer here. What I would say is we predict we'll have enough money. That trust fund has declined over time, mainly because we are further and further away from the stimulus funding that contributed to it in the beginning, and would have run out far earlier had the growth in Medicaid not slowed as much as it has over the last 2 years.
If I can just jump in a little bit, and I know DFA is not here, and they probably have to explain this fully, but as I recall their explanation, I believe it's correct, is that it's really a cash flow issue. That the state, the fund, the DFA has allocated for us, will release to us, they come in later, proportionally later in the fiscal year. So this money was always put in the rainy day fund to be released it now, but it doesn't mean anyway that we're over budget. We actually right on budget based on what we're looking at. We should be fine. It's really a cash flow issue, and we probably need Mr. Sharp here to go into that because ultimately it's DFA that manages the cash flow of the state.
Well, I understand that. Like I said, the private option, we were trying to stabilize our Medicaid, program here, over the last 3 years. Let's see, as of the 2011, I think July 1st, 2011, we had $379 million in the trust fund. Like I said, as of July 1st, I was told we have zero in the trust fund. I'm concerned, in fiscal year 15, we're only going to build it up by only so much, by maybe $40 or $50 million. And, you know, are we gonna, again, be in a crisis situation at the end of fiscal year 15 because we've not done enough to reform Medicaid or do what we need to do to be able, you know, again, in conjunction with the private option as we thought we were, in order to make sure that our Medicaid system is solid.
But, you know, we faced some very big shortfalls. Private option has helped with that. We will not, we are budgeting very tightly. We're trying to be conservative, we're budgeting very tightly. So we believe we'll be okay in 15. As Dr. Ellis said, we don't expect to see the surpluses that we saw during the stimulus period. And as you pointed out, this is, in the discussion we had last year with this body, we cannot simply expand coverage. We really need to reform the Medicaid program and the healthcare system in Arkansas as a whole, and we have to continue with the reforms that we talked about. What we've talked about is payment improvement initiatives and others, because we have to continue to manage our healthcare costs, whether or not we have a private option.
Well, I would agree with that, but again, I'm afraid that we're going down the road with private option, that we're digging a hole, and in a few years, when we have to pay our 10%, you know, right now, we're talking an extra $92.5 million out of the state budget if, you know, based on right now, current estimates that we're gonna have to come up with an extra $100 million to fund the private option, and then we're having our Medicaid.
If I could just interject, I think that the issue here is how tightly the division was budgeted, not increased expectations of cost within the program. So what I hear you saying is that you didn't give us a lot of extra money. That's true. And we remain confident we can manage to the amount that we were given.
Okay,
Thank you
ma'am.
very much. All right, next is Representative Douglas and then Representative Hammer. Representative Douglas, you're recognized.
Yes, thank you, Madam Chair. I just would start off with one question. If maybe Optimus had an explanation on how you think our competition between our carriers has affected our pricing.
Madam Chair, Representative Douglas, I think the competition between carriers has been healthy. We have actually seen a shift in the percentage of enrollment when compared to past enrollment patterns in Arkansas. So prior to the existence of the exchange and the private option, Blue Cross Blue Shield garnered approximately 90 to 93% of the marketplace in the individual marketplace. And that number is approximately 80% in the private option enrollees. As we said, we think the movement towards a continued competitive marketplace in the future will have not only the existing carriers remain, and as Director Allison mentioned, at least one has publicly said they will expand on a statewide basis, but also bring additional carriers into the state. So we think the private option has definitely fostered competition in the health insurance marketplace and provided a platform for the state to continue to foster competition.
How many did we estimate we would have at this time? Carriers.
We didn't make a prediction of the number of carriers. I would point out that the private option was signed by the governor a year ago yesterday, leaving carriers in the neighborhood of 6 weeks to make a decision about whether to play and to participate and how fully to participate in the market this year. Going into 2015, they will have had closer to a year and 6 weeks. And we think that you'll see more of a response in a year and 6 weeks than we saw in 6 weeks.
So we've had one additional one sign on, and how many others do you have knocking at the door?
We can't answer that question. It's really a question to be posed to the insurance commissioner. The opportunity from a carrier point of view was presented, I believe, last week in the publication, the first publication of guidelines for the marketplace for 2015, more or less beginning the period of decision and entry and price setting for carriers with a target towards the end of May. But again, I would defer to the commissioner. So we're in the response period right now from carriers, and I wouldn't have to try to speak for them.
So just to summarize, you don't think our lack of competition at this point has had an effect negatively on our pricing?
I think it could very well have had an impact on pricing in year one, and the intention of establishing a platform which we believe we have for a far more competitive marketplace and more explicitly competitive marketplace in the future, which we do expect to see reflected in lower growth in premiums, if not lower premiums.
Oh, okay, so you think they may even go down. I was interested to see if Optimus knew if other states had auto-enrolled their food stamps population as part of their expansion of Medicaid. Or were we the only state in the nation that did that?
Madam Chair, Representative, I'm not familiar with another state that has done it with auto enrollment into a commercial marketplace, but other states, as part of their Medicaid expansions, have auto enrolled individuals in a Medicaid managed care.
Into managed care, okay. Were you able to look into the future and, it's a great thing to think about the federal government, being able to adjust our cap and pay for, whatever happens with our rates. If it goes to 500 or 550, we're able to adjust that. And they'll pay for that during this 3-year period. Is that what I understand?
Not just for any old reason. So what they lay out is if we can demonstrate if the underlying health costs, which would have affected spending in both the with waiver and without waiver scenario, which is the comparison of budget neutrality, then the adjustment is made. But we couldn't come to them with other rationales and reasons, though that which would fall outside the bounds of fairness, as I described earlier.
But when we look into year 4, how is that adjustment up maybe higher than what I expected it to be? How is that going to affect our budget in year 4 if we keep adjusting this up? Even if the federal government says it's okay and they'll pay for it, do we have from Optimus an estimate on how that's going to affect our, Arkansas budget?
Madam Chair, we have not done further projection out. I will say, though, that the emerging experience from other states is actually that the later enrollments are younger than the earlier enrollments. And so I believe because of Arkansas's pre-enrollment process, we may have masked that somewhat. So it's reasonable to assume, based on other states' experience, that in fact this may be the high point of the average age from a premium perspective.
So did you answer my question? What will that do to our budget in year 4?
If I could interject, I certainly will defer also to, as you posed the question to Mr. Schramm, that year 4, which is beyond the waiver window, it's actually beyond the authorization of the Healthcare Independence Act. Renewal of a waiver in the future, which would likely be a different kind of waiver. Renewal of the Healthcare Independence Act will be conditioned on the success, I am confident, of the Healthcare Independence Act and the private option. So I assume it will be very hard to succeed. And that will make it actually easier to demonstrate budget neutrality in year 4 and following than it was in year 1 or in year 0.33, where we are today. And we look forward to that conversation. I think it will be easier in the future, not harder, and we're certainly hopeful that the trend is at least as low as predicted in the waiver, which is, by the way, lower than long-run historic growth.
But I guess I'm getting a disconnect here because the premiums are going up and we're having more people enrolled in the program than maybe we thought at first we would. And we're having more people that we're moving into Medicaid. And, you know, do we have a projection of how that will, so are you telling me that we're going to have another waiver that the federal government's gonna give us at 100% in year 4? You
No.
didn't just say that.
No, I'm sure that they won't. They'll, I'm sure, stick to the percentages that are in the Affordable Care Act, if not,
Right.
as in this body's determination, there'd be no private option. Let me just correct one thing. I don't believe the premiums have changed at all. Premiums were firm and fixed and announced and on the websites of the marketplace last October 1st and haven't changed. Since then, it won't change until this fall. What has happened is that the mix of individuals participating for whom we're purchasing those premiums has changed. So cost, we don't even know what costs yet are. Neither do the insurance companies, if they're telling us.
But
We'll
that's
find
what
out.
Optimist, isn't that what he's doing? He's making a projection of,
He's made their
Right.
projection, that's exactly right. So we can't say that we've seen a trend yet. We have seen that the average age is a couple of years higher than predicted, partly because we could only have estimated the precise age and demographic mix of the uninsured low-income population, because we only knew so much about that population based on surveys, et cetera.
so I'm not gonna get an answer about year 4. That's
That's what the
okay.
question
We
is.
don't know yet.
Let me try. If premiums, if at the end of year 3, the premiums, the costs were higher than we expected, then if we continue, our burden would be higher also, the state share. 5%, 7%, 10% would be higher also. But we expect that won't be the case. Some of the tools that we have now, some of the changes we're going to make, including the health savings account, we believe will be well within budget. But you are correct. If for some reason, if this doesn't work, which is why I think you all said let's do it for 3 years and see, we'd have a decision to make. I think one of the factors you'll want to consider is, even if premiums have gone up more than we anticipated, if in the overall healthcare market, everybody, including those of us who aren't on the private option, have premiums that are more than they would have been because the market is more competitive, I think that would be an important factor to take into account, because the state as a whole may be better off, even if, we don't expect to happen, even if the private option were somewhat more expensive than we anticipated. I think it'll still be an important thing about that.
Thank you.
Thank you. All right, next on the list is Representative Hammer, you're recognized.
Thank you, Madam Chair. A couple of quick questions. The comment was made about the carriers being consulted in the determination of how to arrive at the 437 mark. Did I misunderstand that, or how were the carriers involved in the process to arrive at the beginning?
Madam Chair, as part of the original work that we did with AID, we did have discussions with the plan management subcommittee, of which the carriers were participants. We, Optimists, had responsibility, however, for the $437 estimate.
Okay, so you're bearing the full blood of that number?
Madam Chair, Representative, absolutely.
Okay. And the carriers that were consulted in the process, are they the 3 carriers that are involved in offering policies in the state now?
Madam Chair, Representative, yes.
Okay. So is it fair to say that if they participated in the process and the number goes off in time, that do they have to bear any responsibility to make up the difference if the number proves to be off in the long run?
Madam Chair, Representative, as part of the contractual requirements for participation in the exchange, there is risk for the carrier. There are components of the exchange that ameliorate that risk. There are MLR requirements, there's reinsurance standards, there's reconciliation to the cost sharing reduction. So there are a number of components of risk that the carriers are assuming as part of their participation in this program.
One of the risks included that they would have to adjust their rates that they're charged in the state to provide those policies down if they contributed in the determination of what the beginning number was or what the projected number was?
If I could maybe extend this and then first to Steve on follow-up. The direct answer to your question is no. There is no legal connection or obligation on the part of the carrier in their informal provision of advice to an actuary and the state's estimate and payment for premiums within the marketplace. So no, there's no formal connection. However, within the marketplace, if a carrier overstates their expected costs by enough, if the experience that they have in utilization and payments this year is far enough below the premiums that they're charging, they will have to give money back to whoever paid the bill, including the state, for the private option participants.
Mr. Hammer, we may also be getting on some insurance commission questions, if that might be more appropriate later. I think it's a reasonable question for this group, if we might look at the insurance commission members.
That'd be great, Mr. Chair. The rate, refresh my memory, are the rates charged differently by region? Okay. Are you tracking, or whose job is it? And as things maybe change in a region, population shifts or whatever it is, it's in the formula, do those changes individually contribute to the overall, and I'm going to use $437 or $477, how are we tracking that to know if there's changes in a region, or is that just absorbed across the board on an average number that's given?
No, the premium figures that are being quoted today are a blend of all of the mix of individuals. So if individuals move between and among regions, if enrollment patterns change, that figure represented that's been quoted, the roughly $500 would change accordingly.
Okay, last question. Dr. Allison, regarding the Medicaid Trust Fund, can you refresh my memory or educate me on how it is that the Medicaid Trust Fund is being, how is money going to make it back into the trust fund if it's low with the understanding that we may have to go back to it in the future? Is there any mechanism in place, or can you?
Fairly certain of this, I'm not the CFO. With the Medicaid trust, of course, it replenishes itself, largely based on soda pop tax. So that'll replenish itself each year. But when the state, at the end of this fiscal year, is able to release more general revenue to us, we'll be able to replace anything that we took out of the trust fund. I mean, reasonably would have come out of the trust, would not have come out of the trust fund except for the fact that the cash flow of the state. Is that, oh.
I guess where I was going is if there's savings in Medicaid, will any of those savings be redirected? I can't remember. Will they be redirected to the Medicaid Trust Fund in the event we need them in the future if numbers are off, projections are off?
Well, we don't actually direct them to the trust fund. What happens, it's the last pool we draw out of generally. So that's what happened during the stimulus period. It simply built up in the trust fund because we didn't draw out of the trust fund.
Okay, and are the medically frail, as it relates to all this, I know there's some tweaking going out between the carriers, and that was an issue. How can you just update us on that, and thank you for the questions.
So the medically frail are those that have been until this month. Only those that had taken a screener at enrollment, and based on the answers to questions about their health status or health use, predicted to need services that weren't offered in the exchange, and therefore labeled medically frail and served through the Medicaid program. About 17,000 individuals have been identified today, and they're receiving services to the extent they need them in the Medicaid program. Not everyone took the screener, and even if an individual took a screener, let's say in October, in an application process or an enrollment process, their circumstances might change between October and April, for example. So we pledged, even in our application terms and conditions, and are working with the carriers to establish a process, which we have now done, through an MOU, a memorandum of understanding with carriers and AID, to allow carriers to identify individuals who they see and believe they might need or likely to need services that are not offered in the qualified health plan. They refer those individuals to the department, and we make a determination about whether those individuals do need those services and need to be determined medically frail. So that process is now underway. We've actually received the first names from carriers, and so we're in that process. We will continue to work on refining the identification of medically frail or exceptionally needy individuals over time.
Thank you, Representative Hammer. Senator Flowers, I have you in the queue next.
Thank you. I read this morning in an article, there are 3 carriers providing policies for the private option.
4, if you consider the 2, some consider the 2 Blue Cross, or some, yes.
They distinguish between those 2. And Centene has 20% of the market. And they also offer this vision and dental service. How much of the cost for the premiums is that? And going forward, since anyone who applies later going forward can, if they fit within the criteria, be eligible for the private option. Going forward, is that going to continue to be offered by Centene? But I want to know how much of those premiums is that amount for that 20%? That, I don't know if it's 20% they got the coverage, or if they got 20% of the market. I don't know if those policies all contain that vision and dental.
They do not. So the individuals that we would auto-assign to that plan, to that carrier, are not auto-assigned into that health plan because it's more expensive, and we auto-assign into the least expensive of the carrier's options in a region. Those benefits will not be included in the private option next year. And those benefits do have a cost attached to them, and the premiums that we're paying for members that are enrolled in those plans with partial dental and vision coverage are more expensive, and that has an impact on our average cost, and will change next year, so that would be, I think, financially to the good for the state, and is one source of mitigation on premiums in coming years.
So people were auto-enrolled in those policies that covered the...
No, it's the reverse. We didn't auto-assign anybody into a plan that had, hopefully, dental or vision. We auto-assigned into the least expensive of the carrier's options, and Ambetter Centene does offer alternatives that do not include dental and vision, and those policies are cheaper. You asked how much more it costs. It's we can't give you a direct answer to that. We know that Ambetter's premiums are higher for those policies that include those extra benefits. We don't know what choice individuals in the private option would have made were those benefits not available. So it isn't as simple as comparing the cost of one Ambetter plan to another. It also requires...
The other 2 carriers don't offer dental and vision, do they?
They do not.
So, I mean, you could.
Well, their premiums are different though. I mean, Ambetters are different than Blue Cross, are different than All Choices.
Okay,
So
well, tell me this. Are you saying that there are individuals in the private option enrolled who have policies with Centene, or I don't know what you're talking about, Ambetter? There was no reference to Ambetter, so that's same, okay. So, so these individuals, how did they get to select dental and vision? I mean, what do you
We established rules at the beginning of the process last year, which said we would buy, but we would give participants the choice of any of the high-value silver plans, which are the ones we're discussing here.
But you didn't give that choice to those that you auto-enrolled.
That would be a distinction, those who are making their own choice and those that we auto-assign, yes.
And so it sounds like, who did you auto-enroll? Those that were already,
Specifically those who didn't make a choice.
did not make a choice, but how was it, how was the process even initiated with them? Were they on rolls, receiving SSI, what?
No, they all chose first to participate in the expansion, in the private option. They simply did not all come through the web-based process of taking the medical frailty screener and selecting a plan. So it's the difference between those two choices that generates the need for an automatic or default assignment to a health plan when they have said, yes, I want coverage and have been determined eligible, but don't go through step 2, which is the actual selection of the health plan. It's those individuals that are auto-assigned. Some of those come back to us in the next month and do make a choice.
Okay, and so, then I understood from, at the last meeting, those policies, actually, some of the carriers are not offering policies in every region of the state, Centene being one of them, right?
That's correct.
Okay, so where does Centene policies, where do those policies fall anyway? What region?
1 second, I do have that. Ambetter is offering in regions 1, 3, and 7.
What parts, do you have a map with that on there?
Yes.
We don't have the insurance department there to make them up.
Okay, I'd like to know that.
We'll be
So-
glad to address that, Madam Chairman, when we get up there.
Do we want to wait until
We
we get
can't.
to that? Would that be okay, Senator Flowers? And
No,
that way
I'm
we-
gonna have to leave
So I think
that a
we'll
little
be
bit,
off.
but if you could send that to me, I'd just like to know, because, you know, I was thinking about it after it was mentioned at the meetings last month or earlier this month, and, you know, I guess it was an oversight on, you all didn't really see that, those extra benefits. That's what I understood at the last meeting, is that right?
That's correct. We didn't know that those benefits would be present until essentially the rates were published and the options were made available.
And so if there is, you know, it just seems to be imbalanced. And I guess I don't blame you all for it, but I was just thinking about a person who qualifies because of their relationship to the poverty level, but the need for that service, it seems like it would have triggered something too. And I thought we were screening everybody went to that next level for determination of frail elderly.
We make not elderly because they're not eligible,
But for the frail.
or exceptionally needy, we make the attempt. We cannot make it a condition of participation though. Income and citizenship and documentation of identity, those are the criteria for eligibility. We believe that the percentage who take that screener will go up over time.
Senator, you're right. I mean, there is inequality, and that's why we're working with insurance departments to make sure there's not one next year. I would note, I think some people think they're getting free vision and dental, and there's a 50% copay.
Right, but.
So it's worth something, but it's not like they're getting it free, but still, we need to fix it.
Right, but I understood, last year, when we were talking about the frail population, how did you call that population?
Exceptionally needy.
Fragile.
Exceptionally needy.
Okay. And so I thought those individuals would be screened for that kind of criteria, and I was you know, whether they, had, diabetes, things, I mean, it just seemed to me like if you, screened a person that was diabetic, that person, the likelihood of glaucoma,
Senator, do you have, do you have a
Well,
question that you're trying to get to, or are we?
well, I'm asking about that particular policy and the fact that you all allowed some to go into it. I mean, at some point, you knew that there was a difference in the offering for Cindi's policy versus Blue Cross Blue Shield. And how come it wasn't used to the benefit of the working poor that we consider, especially needy or whatever phrase you use there?
We did not have a mechanism to extend the mistake through the rest of the state.
Just to be clear, anyone in those regions where that was offered was able to choose that, unless they were the exceptionally needy or medically frail, in which case, we keep them in Medicaid. So we didn't put them in one of the other plans. They stay in Medicaid if they need those additional services. So it's only people who are not the people with exceptional needs who are able to choose. If they didn't choose, we put them in a lower cost plan. But they all had the chance to choose it if they were in one of those regions.
Right, we're going to have to go on. I'm sorry, Senator Flowers. All right, next on the list is Senator Cooper. You're recognized.
Thank you, Madam Chair. What I want to get to is, what I'm hearing is that you don't seem to have a real good handle right now on the true data. A lot of it is estimation. And if competition is going to control costs in the future, at some point we're going to have the true data. And right now I suspect that you're analyzing one thing and insurance companies are analyzing from their standpoint, and they're probably not sharing it because it's proprietary. Do you have a sense of, even from a general sense, of how much additional companies coming into the marketplace would have an effect on the cost? And also, other companies that want to come into the market, can they get in, and is it easy to get in?
I think on the access to the market, we'll defer to the Department of Insurance. I don't know if our actuary has estimates on as more come in with the, which are not, I think we'll defer to the insurance department. Good.
There'll be shortly, Senator Cooper, and I believe they'll be able to answer your question. All right?
Thank you.
Ladies and gentlemen, I don't see any other questions. So I would thank you so very much for your report. It was good to have you come. And Dr. Allison, if you want to, we're going to do a little something funny with the agenda right now, but if you just sit there and let me take an interim study proposal very quickly, then I'll let you continue. All right, ladies and gentlemen of the committee, if you'll go to the last item on your agenda, this is an adoption of an interim study proposal, and Representative Leddy is here to explain it. You're recognized.
Thank you, Madam Chair, and I'll be very brief. We are here to just vote whether or not to adopt this interim study proposal today. We know that meth is a problem here in our state. In fact, just last Friday, police busted up a meth operation in a house in Maubelle. It's not a problem that's limited to any one corner of the state. It's a problem that affects our entire state. And we do have some mechanisms in place currently to combat that problem. I don't know, I for one would like to know more about what we're doing. And I imagine several of my colleagues would too. So that's the entire purpose of this interim study, is to get a better foothold on what we're doing to combat this problem across our state.
All right, would you take a question?
Sure.
All right, Senator Chesterfield, you're recognized.
Thank you, Madam Chair. I move we adopt the interim study.
All right, there's a motion on the floor to adopt the interim study. All those in favor say aye. Aye. All those opposed. You passed the requirement to adopt your article for study. Thank you very much. All right, Dr. Allison, and members of the committee, we're going to go to F, agenda item F, and Dr. Allison, you're recognized.
Thank you very much, Madam Chair. I just had a very brief update. This is a standing item on the agenda, and we have, the agenda item is the primary care case management program, that was part of a piece of legislation passed in 2013. We have now completed the selection process, it was a request for qualification for a PCCM vendor, a company, Community Health Solutions, CHS, has been identified as that vendor, and we're now working with them to finalize contract terms under the terms of the law and the RFQ to begin operation as soon as possible. We're working with them to provide some data and context and making sure that they have the best chance of success going forward.
All right, are there questions? Yes, Senator Chesterfield, you're recognized for a question.
Thank you, Madam Chair. What was in the request
The request for qualification would have fully described, or did fully describe, the PCCM program, the expected terms and conditions, and asked companies to demonstrate that they could meet and wanted to meet those terms and conditions. So, for example, the counties that would be included in the program, the target or minimum number of participants, the methods by which they would be recruiting or securing participation for physicians, the requirements related to patients in the medical home for quality, the kinds of beneficiaries, the nature of the beneficiaries that would be participating, for example, their high needs.
Let me just ask you this. Did you speak specifically to the vendor being able to provide the services in the most underserved areas of the state? For instance, the Delta. Was that one of the prerequisites for choosing the vendor? What are we doing to make sure? Because as I look at the demographics of the state, there are certain areas that are tremendously underserved, and I think you can appreciate that. So I'm trying to find out what you did in the request for qualification that recognizes the health disparities that exist and what that individual will be able to do to alleviate some of that concern that I have for that.
Absolutely. Foremost, there are two forms of compensation within the contract and within the law. One is an advance per member per month payment made to the vendor on behalf of high needs patients. That measure and those numbers of high needs patients are really a direct indicator of need. And so we expect a somewhat higher concentration of high needs patients in the counties that were selected and identified for the PCCM program, and that will lead to a disproportionate number of higher needs patients to participate in the program and to receive those higher payments. So, for example, those payments range from $5 to $10 to $30 per person, and we would expect on average, based on your description of social need, et cetera, that there'd be more $30 need patients in those counties than in other counties.
You have identified those.
Senator, the legislation identified the counties.
Okay. Can I get a copy of that? Just refresh my memory. Like, just
Sure.
give me a copy of that.
Sure.
All right, Representative Collins, you're recognized for a question.
Thank you, Madam Chair. I apologize, because I probably should know this, but this is the first health committee I've been to in quite some time. So when you talk about the Medicaid primary care case management program, does that include recruiting primary care physicians?
Yes, the vendor would do that.
Right, so you anticipate the number of physicians providing services to those with Medicaid increasing?
That would be a different question. So the way that the program works is that the vendor is going to primarily target those physicians that are already serving this population and recruit them into this pilot program.
So you don't anticipate increasing the number of physicians who will accept new Medicaid patients then?
That's not a direct focus of the program. It certainly would be within the bounds of acceptability for the vendor to attempt to increase participation in Medicaid in order to meet the targets of the design of the program.
Okay, and the reason I ask is because I received a call from a constituent yesterday who was terribly frustrated because, and I think her daughter has probably had Medicaid for quite some time, but she is having a difficult time finding a primary care physician who will accept Medicaid patients.
Yes, and we have this pilot program, which is in the process of being launched, and we, in January, launched the patient-centered medical home, which has similar payments for primary care physicians. Also, their rates of reimbursement were increased by the federal government in January, and we think that the opportunity for primary care physicians to participate in the Medicaid program have brightened considerably here in the first part of 2014.
If you have a name, we'd also have constituents who can help her find someone.
Thank you, I appreciate that. And, okay. How many counties are participating in the pilot program?
39. Honestly, the easiest way to think of it is East Arkansas minus Craighead County.
Okay, and so those of us who live in Northwest Arkansas cannot anticipate seeing that increase in physicians?
Well, there are two things going on. Statewide is our patient-centered medical home, where we make payments directly to physicians to manage these same types of patients. And we do think that will make it much more attractive to be a primary care physician. Then, as a pilot, if you have this thing, there's this alternative program called patient-centered medical home, where we're paying a vendor to work, really help those physicians manage those patients. It's really kind of a choice, at least in half the state. But for this particular program we're talking about now, no, it's not available in Northwest Arkansas.
Thank you. Thank you, Madam Chair.
All right, thank you. Representative Hammer, you're next.
Thank you, Madam Chair. Do you know, have you looked at the increase of doctors wanting to come into the state? I remember somewhere in all the discussions when the debate was going on that this would enhance bringing in doctors from out of state because it makes it more lucrative and they'd have access to the population. So if y'all running numbers to see as far as the number of doctors?
We haven't made numbers. I don't believe we made a specific prediction. I'm sure we expressed a hope, but I don't believe we promised that the number of doctors moving into the state will increase or change over time. I certainly, I wonder whether a physician in another state might wait a year or two to see what their state does with regard to coverage and payment policy. I don't know if the physician would make a decision based on a few months.
Right, and I didn't mean to imply what the officers made. I just knew there was an expectation in the argument that it would make it easier to recruit doctors into the state. And I'm just wondering if y'all tracked that to see if there's been an increase in doctors trying to get into the state or not. So,
Stewart.
okay, all right, thank you, Madam Chair.
All right, thank you. Senator Sanders, you're recognized.
Thank you, Madam Chair. I would want to offer this, as I understand it, the distinction between the patient-centered medical home and the primary care case management is that the PCCM model is more targeted to those high needs, high cost patients rather than the patient-centered medical home, which is sort of everyone. So I mean, you may have someone who is sort of a low needs person who's on Medicaid, but to couple with a high need. So the idea was these are people who are key cost drivers, and this is an effective way of managing down the cost of these these high utilizers
I
outliers.
think that's a fair assessment, that the focus of the PCCM pilot is narrower on that high needs population than the focus of the PCMH, which is focused on transforming a physician's entire practice and includes both the high needs and low needs. I would draw one more distinction. The other key distinction is, which is also an interesting comparison. One reason that the pilot has such value, and that is the PCMH program directs the additional payments and the opportunity to secure care management services directly to the primary care provider. And so the money goes to them, the gain sharing from reducing overall cost goes to them. They can choose to hire a vendor of their own to perform case management type services to help reduce those costs, but it goes to the doc. In the PCCM program, the money goes to the vendor, and the vendor presumably presents a package deal to the physician, but the money goes directly to the vendor. The gain sharing is with them, and then at a percentage between the vendor and the physician. So it's two different models. One's more targeted and with a sort of different role for the primary care physician himself.
Okay. I think it's a very important distinction to make. I mean, I think there's sort of there's obviously a higher risk when you are ordinarily focused on a high needs population. So I think that needs to be considered, because obviously with patients that are medical home, you're looking sort of across the board. And to your point, where you're seeing just practices built around that, what you have is someone who's given a specific task here with PCCM to manage the care of a particular population in a particular area, in an area which we know historically, and from the data, we see higher occurrences of hypertension, diabetes, all those things. So it's very important. And the idea is we knew that there would be medically needy coming on to Medicaid rolls as a result of the private option, as a result of the medically frail screener. So I think this is a very important model, and look forward to more updates and where we are in terms of getting this, getting it implemented and getting everyone supported.
All right, thank you very much. Representative Ferguson, you're next.
Thank you, Madam Chair. Listening to Senator Sanders, it brought up a question that I had not thought of before. Can a physician participate in the medical home and the case management model? In other words, could he use the medical home for his less sick patients, and then for those high-risk patients that require a lot more management on the part of the physician, could he contract with case management people for those sicker patients?
Absolutely. They could even choose to use this very same firm. In that case, the financial arrangement would remain with the physician, and the payment for case management services would come through them to the vendor. But in fact, we expect to see precisely that arrangement among the patients in the medical home participants.
All right, thank you. Representative Hodge, you're recognized for a question.
Thank you, Madam Chair. I appreciate your patience. What is the impact on those physicians we've been discussing of the patient improvement plan? How is all that tying? Patient payment improvement plan. Yeah, I left that one piece, sorry.
Well, there are really two major pieces to the payment improvement plan. One is the episodes of care that we talked about. In fact, I'll give a little more information on that later today. The other big, and that's for, it's simple as when you're sick, how we help physicians manage your care, and providers work together. The other big piece of that is trying to keep you as well as possible, and that's what this patients in the medical home and the primary care case management help, which is really supporting those primary care physicians and doing the kinds of work with their patient panel. They tell you they want people, they need the resources and the time to do it. So this is a core component of home improvement.
Thank you.
Seeing no other questions, I appreciate your report, and I believe, Mr. Seelig, you're going to stay for another item, is that right? Okay. All right, next on our agenda is item E. This is the Insurance Department, Jay Bradford, the Commissioner, and Cindi Crone, Deputy Commissioner. So if you'll come forward, please. All right, if you would recognize yourself for the record, you'll be recognized. And we do have a handout. It's in your packet. It's item E.
Thank you, Madam Chair. I'm Jay Bradford, Commissioner of Insurance, and I'm our right. Cynthia Crone is Deputy Commissioner in charge of the Connect project, and on her right is Amanda Spicer, who's our Finance Director for Connect. I'll give you a brief opening here about where we are, what we're addressing this segment, and we're actually addressing the people who are not on private hospitals, people that are over 138%. That is people who have to connect through the federal exchange in order to secure the insurance. Those people are covered by tax credits based on their income as is verified by the Department of Treasury. You'll remember that the federal guidelines were extended where people who had started to enroll before the period of enrollment expired, and also people who had actually enrolled on a paper application before. So what happened in the last few weeks after the enrollment date, there was another 11,000 people who secured protection through the federal exchange, giving Arkansas members a total of 44,665. That's April the 21st. That closes the deadline for the people who are over 138%. The only way that they will be able to apply would be if they have a change of life issue, which is divorce, loss of the job, age out to parents, policy at age 26, and an adoption of a child. That population will be able to apply again for the next plan year. The enrollment period will be November 15, 2014, and will close February 15, 2015. And there again, those are the people who are not under the private option. So the population of by county of these people, as you would expect, the 10 largest counties in the state have the most people who apply and then issue policies, which is Pulaski County, Washington, Garland, Parker, Saline, Sebastian, White, Jefferson, and Craighead. Some of the rural counties who have a lower population but have a lot of people who would qualify for the private option, they have the greatest percent of increase based on their population. And those counties, and you'll recognize them as more rural areas, which is Shea, Drew, Ashley, Baxter, Newton, Woodruff, Chico, Lee, Phillips, and Monroe County. So those people have the greatest percentage of growth, but their numbers are not, of course, as high as the population counties. We'll be glad to address the competitive issues. I'll respond to your questions on that came up in the Medicaid section of this. And Cynthia, who is actually the person who does all of this on a day-to-day basis, she's very dedicated. She'll be able to get down in the weeds if you have those extra questions, as will Amanda, the finance person.
All right. You recognize if you want to add more to that.
Thank you. The one thing I would add is that the paper applications that got in by April 7th can have people enrolled through April 30th. So this is not the final number. We'll see some more come in the rest of this month. But I think, as the Commissioner said, this is most of them. We have the maps showing the increased enrollment. We did have a 33% increase from the time we were here last time, and that was not unexpected. A lot of people waited until the end to enroll.
it might be noteworthy that those late people with the younger population that typically will wait and are computer savvy. And so they're able to get in and extend the deadline. So that's how that developed, I'm sorry.
We did look at our population age, though we talk about how much private option helped over 138%, and it certainly does. It brought us up to a 60% in that under 44-year age range. Even without that, we were ahead of the federal average by age. And we really are approaching with private option an average age that is the national optimum. So that's looking really good